All right. So thank you so much for joining me and offering me the opportunity to speak. I have done one of these lectures before, and it was a great opportunity to meet people across the world and, collaborate and talk about how we do things similarly and differently. So, my expertise is in male sexual and reproductive health. So I completed my fellowship at the University of Washington in andrology. So really focused on male infertility and then the sexual health aspects of men's health, including erectile dysfunction, as well as Peyronie's disease, cancer survivorship after prostate cancer surgery, typically. And obviously one of the main things that we see is erectile dysfunction. And so there's a lot around the mechanisms and management that I'm going to share, and then happy to answer any questions. Let's see. Okay, those are my disclosures. So the objectives of the talk are just to define the scope of the condition, to identify the major causative factors of ED, and to describe a guidelines-based approach to evaluation and management. And then we'll kind of briefly discuss the new frontiers in management and, how I feel about them and how I'm interpreting some of the literature in these new frontiers. So ED is extremely common. We know that it increases in prevalence with age, and that 30 to 50% of men have ED from ages 40 to 70. The global prevalence is suggested to be almost close to 80%. And that, of course, is correlated with age and health status. And we know that severe ED increases as men get older. There was also a rise in awareness and diagnosis of ED, which may have sort of inflated the incidence of ED. So in 1998, Viagra was FDA approved here in the United States. And this company that produced Viagra, Pfizer, started using direct-to-consumer advertising, and they escalated their direct-to-consumer advertising significantly. So in just 7 years, by 2005, Pfizer, which produces Viagra, and Eli Lilly, which produces Cialis, were in the top 20 worldwide spenders on direct-to-consumer advertising, equaling about $190 million just that year. And so there may have been an increase in awareness, but there's also truly organic mechanisms for erectile dysfunction. And I always talk to patients about the fact that we think erections should be things that men get all the time on demand, and often in the media they're portrayed as things that just arise when men don't want them to, but really it's a complex mechanism, complex machinery. A man needs an intact vascular health. He needs healthy penile tissue. He needs neurologic function. He needs good endocrine function or testosterone. And he needs to be free from anxiety to get a good erection. So all of these things have to coalesce perfectly to really produce a good erection. And so any insult to any of these elements can produce erectile dysfunction. So some of the major causes of ED are the insults like I previously described, the greatest of which can be vascular. So 40% of erections are thought to be related to vascular issues, and 30% can be just specifically tied to diabetes. Diabetes, of course, causes insult to the vascular system and to the nervous system, and so it's sort of a two-hit phenomenon. Other etiologies, including medications, prior pelvic surgery, etc., are listed here, are smaller, but mostly we see vascular and diabetes being primary organic causes of ED. And why is that? So the pathophysiology of cardiovascular disease and ED is very similar, and they all really, the two disease states of cardiovascular disease and ED are linked to endothelial dysfunction. So many things in terms of comorbidities like tobacco use, obesity, sedentary lifestyle, psychological stress, and of course, true medical comorbidities like hypertension, diabetes, hyperlipidemia, can all contribute to endothelial dysfunction. And endothelial dysfunction thereby contributes to both erectile dysfunction and cardiovascular disease. So really the root of the problems are similar. And that's why we think of, ED as sort of a canary in the coal mine for cardiovascular disease. Men with ED have a 1.7 times risk of premature mortality to those who don't have ED. And the odds ratio for men with ED versus those without for cardiovascular disease is 1.4. So definitely a significant higher risk of cardiovascular disease and mortality in men with ED, and should be sort of a red flag for us to think about, are these men getting in to see their primary care doctor? Are we managing diabetes? Do we need to look at, some of the contributing causes? And I'll kind of talk about that in the evaluation. The other important thing that we know about ED is that it both results from mental health issues, but can also cause mental health issues. So erectile dysfunction is associated with depression, anxiety, decreased quality of life, lower levels of physical and emotional intimacy in partners, and lower relationship satisfaction. And when we treat ED, the studies have been done with the oral medications. Treatment for ED improves the partner's quality of life as well as sexual function, in addition to the patient himself. So lots of sequelae, mental health sequelae from ED, but of course, anxiety and things like that, as I mentioned before, can also produce sort of psychosomatic erectile dysfunction. So how do we best evaluate and treat our patients? And I really favor using a guidelines-based approach. And while there are many guidelines, including the EAU, the Canadian Urologic Association, I really rely strongly on the American Urological Association guidelines, which were republished in 2018. And so the AUA guidelines go over the ED evaluation very specifically. And they say that men with symptoms of ED should undergo a serological, medical, and psychosocial history, physical exam, and laboratory testing. And then furthermore, they mention specifically testing for testosterone. So my evaluation starts generally with a very prolonged history. So I talk to them about their medical history, their sexual history. Are they partnered? When did the ED arise? Is this specifically with a single partner, or has this been a lifelong issue? Are there any new psychosocial stressors going on? Is it, did they lose their job? Are they, was there some link like COVID, for instance, and men have new onset ED because of the stresses of the pandemic? We talk about orgasmic dysfunction. Is there an issue where they're having new onset premature ejaculation, which can be linked very closely with ED? Or is their orgasm delayed and they're sort of running out of steam, and that's what's causing their ED? Are there other elements of sexual dysfunction in terms of Peyronie's disease? So is there a new curvature of the penis? And so that also can come hand in hand with ED. We talk about their libido. How good is their sex drive? Is this truly a testosterone issue, which can be hinted at by a reduced sex drive? And then again, just talking about relationships and other medications they're on that can contribute to erectile dysfunction. I do a focused physical examination focusing on the virilization of the man. So whether he has a full beard, facial hair, if I perceive gynecomastia that may, tip me off to an endocrine dysfunction. I do a vascular assessment, just briefly checking pulses. And then I do a very focused genital exam, and that, really focuses on the penile health, whether there's any fibrosis of the corpus cavernosa, whether there's any penile plaques suggestive of Peyronie's disease. I check testicular size, which again sort of alludes to their endocrine function. And that really kind of is the majority of the exam. I do offer laboratory assessment just based on our guidelines. And so I check a serum testosterone as well as an LH. And the reason why I check a luteinizing hormone is to get a context for the testosterone. So if the testosterone's low, I really want to know what's going on upstream of the testosterone to get a context for that. Otherwise, you're sort of, you can't really answer the question of, do we need to replace this guy's testosterone? I also always consider getting kind of a more full laboratory history in terms of checking for diabetes, checking for erythrocytosis. And so that includes a hemoglobin A1C, a CBC, a lipid panel, and a BMP, especially if they don't have a relationship with a primary care doctor. We also talk about the cardiovascular risk assessment. So as I mentioned, ED commonly precedes cardiovascular disease. And so the AUA guidelines describe that we should be counseling men that ED is a risk marker for underlying cardiovascular disease, and they may warrant evaluation. And in particular, I'm concerned about this when I have a man who's young, who may have a history of cardiovascular disease. So that's part of my history as well. Or is there any, early onset cardiovascular disease in your family? We also talk about their comorbidities and risk factors, particularly tobacco use. So if they're smokers, I definitely talk to them about the risks of both cardiovascular disease and ED related to their tobacco use. If I have a strong suspicion that this is an early onset cardiovascular disease that hasn't been evaluated, I would consider referring them to cardiology or internal medicine. And then other workup, might include EKG or stress test. So always at the forefront. We then have to consider whether we need to do any specialized testing. So the AUA guideline statement 5 states that for some men, specialized testing and evaluation may be necessary to guide treatment. And historically, there have been a number of kind of adjunctive tests that we use, but the main one that has stuck around that is, I think, really informative and the most widely used is the penile duplex Doppler ultrasound. And I'll kind of talk a lot about how and when I use that. Other tests that are not as commonly performed anymore are the RigiScan, which is a nocturnal penile tumescence test, biothesiometry, so measuring perception of vibratory sense, and so that's sort of a neurologic test. Cavernosography and cavernosometry, really invasive tests looking at penile blood flow, but don't really change management, and so are not used as commonly anymore. And similarly with penile arteriography. So penile Doppler ultrasound is the one sort of adjunctive test that I use. And what this provides is an objective vascular assessment. So it gives me the patient's peak systolic velocity in the cavernosal arteries, the end diastolic velocity, and our resistive index. And there are some parameters that are truly indicative of an arterial insufficiency. So that is when peak systolic velocity is less than 25 to 30 centimeters per second. That's indicative of arterial insufficiency. When the end diastolic velocity is elevated, which is common in older men, that's more indicative of venous leak, and it can be common to have both. Our ultrasound machine calculates a resistive index, and so if it's greater than 0.80, that is considered to be normal penile blood flow. I do the procedure by first obtaining pre-injection cavernosal artery measurements. So I just measure the diameter of the artery. I then deliver an injection, intracavernosal injection of alprostadil. Usually I use alprostadil in our clinic because it's shelf stable. I don't need to refrigerate it. It's packaged in a single vial. And so it's easy to use in clinics. Some practitioners use Trimix and favor that for their intracavernosal injections in clinic. After the injection, I give the man about 10 minutes for the alprostadil to work to get his erection, and then I re-obtain those artery diameter measurements, and then I perform the Doppler flow study where I obtain the peak systolic velocity, end diastolic velocity, and the resistive index. If he has a really good response to the intracavernosal injection, I will deliver phenylephrine just to reduce the priapism before he goes home. And in terms of the data, so peak systolic velocity indicative of an arterial insufficiency is associated with a threefold increased risk of major cardiac events. And this just goes back to the fact that we as urologists really have the chance to intervene in global men's health when we see things that are suggestive of cardiovascular disease, like, a reduced peak systolic velocity. I do think the penile Doppler duplex ultrasound has a lot of utility and I use it commonly, but there are some limitations. And most notably that there is high inter and intra user variability. So, based on each time a man comes in, there may be, you may get a kind of a different response to the medication and how you perform the exam, whether you do your Doppler ultrasound at 5 minutes after injection versus 8 minutes after injection versus 10 can vary things. As you'll see in those graphs on the right, depending on where you actually do your measurements of the flow, whether it's in the crus of the corpora, in the proximal corpora, or along the mid shaft, there are differences in your peak systolic velocity. So I find it's helpful for me to just do it the same way every time. And that way I have kind of a gauge just based on my own experience. As I mentioned, there are important factors in doing this exam, including what phase of the erection the gentleman is in, what model of ultrasound you have. Some are more sensitive than others, where you place the probe on the penis. And then, there is the possibility of getting a false positive. So I have seen young men who come in who have very high anxiety, and they can actually sort of produce this false positive venous leak just because their sympathetic tone is so high that they're not getting great blood flow in the penis. And, it leads to this false positive. So before I do a Doppler ultrasound, I always ask myself, will this impact my management? And where I usually obtain the duplex is in men with young age, and I have a high suspicion for heart disease, and I'm really evaluating him for arterial insufficiency. I do it in men where I have concern for psychogenic ED, with that one caveat that I think if he's extremely anxious, we may have a false positive for that, telling him he has a vascular problem when it's really just anxiety. When patients have a strong preference for having objective measurements of their penile blood flow, I will do this exam. And then I use it very often in men with Peyronie's disease. So that's going to help me look at a penile plaque along with their vascular integrity. So now we're sort of going to branch into more the treatment options. And what I like to tell patients is that this is one area of medicine where we actually have kind of a deep toolbox. We have a lot of things to offer them. And these are just some examples. The AUA guidelines made a statement that really it came to the heart of patient counseling, which is that we can offer any of those options to patients right up front. They don't have to graduate from a pill to use injections to get an implant. There's no requirement that they go step by step. Many men like to go step by step, but there's no requirement. And so any treatment as an initial treatment is a valid choice, as long as they're aware of risks and benefits. And so these are our options, and this is sort of the guidelines-based approach in the AUA guidelines. So we have our gentleman in the center with ED. Generally, of course, we do start with PDE5 inhibitors like Viagra, Cialis. And then, I do counsel them right away, though, on the more advanced treatments kind of on the bottom. And those statements from the AUA guidelines correspond to each treatment option. The one area that I'll talk a little bit about, that is very rare to use is penile revascularization. And there is an AUA statement on this that revascularization of the penis is really only indicated in very young, healthy men with a focal arterial occlusion that we can actually revascularize and give him back penile blood flow. I have a lot of older gentlemen asking me about, whether there's something they can do. They have heart stents. Can we stent the penis? And we have to just kind of remind them that that's not possible in the penis. And really, there's only a specific indication, which is in a young, healthy man. These are often men who have a history of trauma. So the first thing we typically start with is phosphodiesterase 5 inhibitors. And here, at least in the United States, we have kind of a large variety of what to use. I do often talk with patients about all of the different options, although most of my patients either use sildenafil or tadalafil because they are generic, they're lower cost in general. They have heard about them, so they're familiar with, the drug. And really why I differ between the Viagra and the Cialis is because the sildenafil Viagra has to be used on demand. It is more reliant on whether a man has had food, and so there's some dietary restrictions when it's taken, versus tadalafil, which has a longer half-life, greater ability for spontaneity, so really good for sort of the younger age group, men in their 40s and 50s, if they have kids around and timing things with their partner is more challenging. It's easier to just use the tadalafil because it's in their system all day. And of course, there's no dietary restrictions with tadalafil. I rarely ever use the vardenafil. Usually I use that if a man has failed the sildenafil and tadalafil or has side effects and just asks to try a different type of pill. I have very rarely used Avanafil, but it does have a very short T1/2, so it is it's something that can be quickly used on demand. While I discuss all of the options, I do share with patients that the side effects are largely the same, and most commonly include headache, facial flushing, sort of GI, heartburn-like symptoms, and then nasal congestion. And these can definitely be limiting in their use, in addition to the absolute contraindications. So if patients are on nitrates, of course, I do not prescribe these drugs if they even have a prescription for nitrates, unless they reassure me that they haven't needed their nitrates in 5 years and it's just on their med list. Secondly, untreated, unstable cardiovascular disease is a contraindication to use of these medications. If a patient, has side effects or does not like the use of PDE5 inhibitors, or they do not work, then we usually go on to the other options. And as I mentioned, I always talk with men who come to me all along the process about all of the options, and that I really want them to be able to both like the treatment and have it work. And so, the world is their oyster in terms of what we can do. I want them to find a treatment that they like and that works. And so the more advanced treatments are those listed below. A vacuum erection device and a constriction ring is something that men commonly use here because it is both easily available and cheap, and studies do suggest some high satisfaction rates. So I discuss this with men in addition to the oral medications or just on its own. And so this works by means of suction. The cylinder is fit over the man's penis, and a steady amount of suction is pulled into the penis, and then a constriction ring is placed at the base of the penis to act to help control some of that venous leak. Another pro that I didn't really mention is that there's no systemic side effects because this is just working locally by means of suction. The downsides, the disadvantages are that this device can be cumbersome to use, and it is, men describe it as sort of not a real erection due to the constriction ring. It can lack some of the normal feel and the normal sensation that they have. And then men with Peyronie's disease have difficulty using this because of the curvature, and it really requires a very straight penis. Relative contraindications to use of a vacuum device are when men are on anticoagulation, just because they can observe bruising afterwards. I tell them in advance that they may expect to see some bruising, but you know, they usually are fine with that. One area where I really like to use the vacuum device is in men after their radical prostatectomy. And the reason why is I tell them it sort of acts like a penile push-up. So the penis is an organ that is not like our liver or our kidneys that are constantly getting blood flow. It really only gets blood flow when a man is getting an erection. And so when a man is in this period of sexual dormancy after his radical prostatectomy, I think it's important to encourage blood flow to keep that tissue healthy, so that while he's healing, these medications have a greater chance to work and, on a healthy penis, because that's part of the whole machinery. The next most commonly used sort of low-level invasiveness treatment is intracavernosal injections. So these intracavernosal injections are very efficacious. I think that's one of the main advantages, is that they work very well. And a small vial, while it's not as inexpensive as the pills, can be used many different times. And so over that course is affordable. It's relatively easy to use, especially if men have any experience with using insulin needles, or if their partners have, any medical background. They achieve use very easily. Some of the disadvantages are that men don't want to use needles on their penis, and that's absolutely reasonable. Some men have a very strong needle phobia, and those would not be great candidates for this treatment. Pain can be associated both with the needle injection, but also with the medication itself, which can produce some aching, because, one of our main medications is a prostaglandin. And then my biggest concern is always for priapism. So these medications are efficacious, but they can be too efficacious. And so we counsel them. I'll kind of describe the way we teach them to use it, but that's, something that they need to be warned about strongly. They are encouraged to only use it 2 to 3 times a week. So for men who are more sexually active, this may not be the best treatment. And then it can be limited in terms of its use in more rural areas, because it needs to typically come from a compounding pharmacy. The other thing that I do talk about them is that while I do think it's a great treatment, the discontinuation rates are quite high. It may be because of the refill and just the need to draw up medication that's sort of a barrier to use, or that they, favor some other treatment option. The main risk factors for discontinuation, similar to other treatments, is increasing age and partner age, use of or history of diabetes, and a history of radical prostatectomy. So what we do in our center is a very thorough teaching session. Our patients have a dedicated visit with our PA. She's our physician's assistant, and in other centers they use nurses or other advanced practice APPs. We have a lot of handouts and videos that we show them. And if the partner can be there, that's very helpful to kind of go over how they're going to draw up the medication. If one has bad eyesight, the other one can help, things like that. We do a test injection, and we usually start with a very low dose and encourage them to do the same at home. They may get a better response at home, even if they don't get a good response in the office, and then they can titrate up very slowly. We have our APP, again, follow them up at about 6 to 12 months, just to talk about efficacy and to do a physical exam to rule out any fibrosis due to the medication. So that's how we do intracavernosal injection teaching. I've very rarely seen men who have this kind of teaching come in with a priapism to the ER, but I have seen it with our next treatment, which is intraurethral alprostadil. Obviously similar medication to what we use for the intracavernosal injection, although this is just a single agent alprostadil. One of the benefits is that they don't have to use a needle, and it is very easy to use this small applicator to insert this little urethral suppository into the distal urethra. But men, can be a little squeamish about this as well. The disadvantages of intraurethral alprostadil is just that there is low efficacy in some studies, less than 50%, and that the efficacy is very dose dependent. Similarly, dose-dependent side effects occur, including pain and burning, which can extend to the leg and testes. And there are some reports about partner discomfort after use of intraurethral alprostadil. Lastly, this is very costly, and very rarely is it covered by insurance, although our VA hospitals do have coverage for this medication. So that's where I see it used most. There are some alternatives that I do speak with my patients about, although these are newer, and the utilization, I think, is less overall because they are newer. These include topical gels, so intraurethral gels, and topical gels. So the topical gels work quickly, and they're the same medications that we use in the injections. They are shown to have some good efficacy, but can cause a lot of local irritation, and then they're not FDA approved. I have had a few patients use intraurethral gels. So this is sort of a small syringe of a gel that's squirted down the urethra, similar to just using, intraurethral lidocaine before a procedure. These are obtained from compounding pharmacies, and there is not very much data on these yet, so not used very commonly. Many men, while one therapy may not work very well, may combine with another therapy, and we do talk about this. So very commonly, especially after radical prostatectomy, we combine the PDE5 inhibitors with the vacuum device, and we see a very good improvement in rigidity and sexual satisfaction. You can also combine the PDE5 inhibitors with an intraurethral alprostadil. The intraurethral alprostadil may give a little more rigidity to the glands and the spongiosum, while the PDE5 inhibitor works more on the corpora cavernosa. Rarely do I combine the PDE5 inhibitors with intracavernosal injections, but it is definitely possible. And with all of these medications and combinations, I always recommend that patients start low and go slow. So we start with a lower dose of the PDE5, low dose of the intracavernosal injection, and then we sort of counsel them all along. And that's where it's really helpful to have a advanced practice provider with you who treats ED regularly. The option that I talk to men about starting from day one is our most invasive treatment, of course, but very high satisfaction, and that's the penile prosthesis. And so the penile prostheses come in many forms, and I talk to men about all the different sort of styles of penile prosthesis right from the beginning. Obviously, we have a malleable prosthesis, which is the semi-rigid, sort of considered to be the rods, versus inflatable. And then when we talk about differences of inflatable devices, there are 2 pieces and 3 pieces. And I find that most men favor the 3-piece because it's the most lifelike. And that's what is most commonly done here in the United States. Although I know that malleables, the semi-rigid implants, are done more commonly in Europe. I'd be interested to talk to you about what is most commonly done at your centers and, why that's driven that way. In terms of the inflatable penile prosthesis and really the malleable, the strong benefit is that it gives men a firm erection whenever they want for as long as they want. And this is the only treatment that we have that guarantees them spontaneous sex again, because it really works on demand. Whereas the pills and the injections, may be a little unreliable and take some time. It also doesn't impact their urination, their ejaculation, their orgasm, or their sensation. And so those are really nice aspects to the prosthesis. studies have shown extremely high patient and partner satisfaction rates. And I think, largely because these men have had sometimes periods of many years without being able to have spontaneous sex, and this gives that element of their life back. The disadvantages, of course, is that it's invasive. It means they have to go through a surgical procedure, and there are risks to having the implant in, like infection, mechanical malfunction, and perceived shortening of the penis. When we talk about penile prosthesis, some of the pearls I talk about with our trainees of discussing this with men is that I bring it up early as, one treatment option, and I don't say this is our last resort. I just bring it up as an option, but I don't really push it on patients. I think it's reasonable for any guy who does not respond to a PDE5 inhibitor to consider a penile implant, as long as he's healthy enough to be having sex and healthy enough for surgery. I give a lot of teaching about the implant and give them a lot of resources. So there are good websites, there's a lot of handouts, there are a lot of pamphlets that are both from my team's resources, but also from the device companies. And then, we have device patient advocates. These are men that have implants in and are willing to talk with men considering surgery. And so those are really good resources for us in counseling men. I do consider using a penile duplex in men who are contemplating a penile prosthesis, just to give them some objective information that they do indeed have vascular ED, and this may be the best treatment for them. Again, just to go back to my treatment philosophy, is that I really discuss all of the treatment options with men as early as possible, including all of the pros and cons that I just described to you. They're aware of that right from the get-go as well. And so I always ask my men, my male patients with ED, does this treatment work and do you like it? Because this, we're treating sexual dysfunction. It should be fun. It should be restorative. And so they should stick with what they like and what works. One very important facet to my counseling that I didn't really describe yet is lifestyle modification. And this, again, harkens back to the endothelial dysfunction that is common to cardiovascular disease and ED. And I definitely make this a part of my counseling that men should be engaged in smoking cessation, physical activity, weight loss, reducing their alcohol consumption, stopping use of illicit drugs, reducing their mental stress, and then sex therapy, particularly for young men. I refer a lot of men to the American Association of Sexual Educators, Counselors, and Therapists, especially in young men where I think this is mostly psychogenic. And there are a lot of sex therapy focused podcasts that have been very good resources for some of my younger patients, or even some of the older patients who are cancer survivors. And, there are podcasts on cancer, sexuality, and cancer survivorship. So lots of information out there, and very important to make sure that their overall health is as optimized as possible. We know that all of these things can help with erections. There have been a few randomized trials, mostly out of Italy. And so I talk about this with all my patients. The last thing to talk about is some of these regenerative medicines. So regenerative medicine is described by the National Institute of Health as the process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. In an erectile dysfunction, there are three sort of main categories of regenerative medicines that are being studied and are being used here in the United States, including low intensity extracorporeal shockwave therapy, stem cell therapy, and then platelet rich plasma. I think it's really important to talk about these things amongst urologists because while we are treating men with all of the most approved and up-to-date therapies, there are, at least in the United States, many clinics where these are not urologists, they are not necessarily even physicians treating men with these therapies without significant, data to prove what they're using. And it's really very predatory. And we have to be able to kind of describe to men why these therapies may not work and why those clinics may not have their best interest in mind. So the proposed benefits from these treatments are to restore spontaneous erections and the responsiveness to the low-level therapies. The goals are to create angiogenesis and neovascularization by upregulating some of these factors that I listed here, and create neurogenesis by, again, upregulating Schwann cells and TF3. Low intensity shockwave specifically is the therapy that's similar to what we use for stone treatment, and it creates acoustic disturbances that propagate through tissue. We don't entirely understand the biological mechanism, but we think it relates to creating tissue compression and expansion, which creates localized membrane stress and then production of angiogenic factors, which then, create new blood flow and restore erections naturally. There's a lot of diversity in the treatment modalities in terms of the shockwave devices. So there are different hand pieces, different gel applicators, different shockwave machines, and all of these elements can be highly variable and are variable in the studies. So things like the energy flux density, hertz, and the total shocks used are highly variable. There's no defined treatment algorithm. And this, has implications in our studies and how we counsel patients. So this is just a very busy slide showing all of, a summary of many of the low intensity randomized control trials. But the takeaway points are that there are studies that show benefit over placebo, and that there was a meta-analysis that does support the benefit of using shockwave therapy to improve man's erectile function. However, there are variable populations. So the studies tested kind of a wide variety of men with mild ED versus severe ED. And again, there's no distinct settings of the energy. And so the optimal treatment protocol is unclear. What I tell patients is that shockwave may be useful, and it certainly is more useful in men with mild ED rather than moderate to severe ED. If a man is not responding to PDE5 inhibitors, I don't think he's going to benefit much from shockwave therapy. It is helpful when he's using PDE5 inhibitors concurrently and relatively healthy. But again, we don't really know the optimal treatment duration and whether the treatment effect is maintained over time. So they may need maintenance therapy. This bar graph just shows that men with diabetes and severe ED had very low success rates at improving their erectile function at 2 years with the use of shockwave therapy, whereas men with no diabetes and only mild to moderate had a much higher success rate at 2 years after low intensity shockwave therapy. The next category of regenerative medicines is the use of stem cells. And so these are mesenchymal stem cells, including adipose, bone marrow, placenta, and urine. And these cells are minimally immunogenic. So they can be used they can be autologous or they can be allogenic. And what we think they do is they create a paracrine effect. So they may create some immunomodulation in the penis, which increases the cytokines and growth factors similarly to shockwave. And then they allow for recruitment of more of your own endogenous stem cells to then, of course, regenerate tissue in the penis. These are some trials listed again. Takeaways being the studies on stem cells have very small cohorts. There are generally no controls. And again, the patient populations are highly variable and treatment protocols are highly variable. There may be some signal of benefit, but not yet approved or recommended. by our guidelines. Lastly, platelet-rich plasma requires a man to go through whole blood centrifugation. PRP, or that sort of, there's a small segment of plasma that has a 4-fold increase in platelets and growth factor concentrations. And so these PRP is thought to release PDGF, some of these other growth factors, and animal models has been shown to produce some neurogenesis, reduction in fibrosis, and reduction in penile apoptosis. There was a small study from the United States that did demonstrate safety and feasibility of PRP injections for both ED, Peyronie's disease, and stress incontinence. And this very small cohort of men had an improvement of 4 points on the IIEF score above, though their baseline was not reported. And importantly, there is a large proportion of men that would undergo further PRP, perhaps because, again, it's minimally invasive and they would like that restoration. But our AUA guidelines do consider these treatments investigational and experimental. The Sexual Medicine Society of North America also strongly supports the development of novel erectogenic therapies. But while these treatment modalities may be plausible and their mechanism of action may be scientifically sound, we need more rigorous experimental data to conclusively validate them. Again, they consider these experimental and should only be conducted under research protocols. So our take-home points are that history and physical exam are really critical. And I have a very low threshold for cardiac evaluation, especially in those kind of younger patients, especially with a family history. Penile duplex Doppler ultrasound has utility, but I use it judiciously. And that any form of treatment as the initial treatment is valid. I strongly encourage patient selection and really good patient counseling, and asking men, does this treatment work and do you like it? And that our visit with these patients is a really great time to reiterate the importance of healthy living. And then lastly, the regenerative therapies need more data. So I want to thank you so much for the opportunity to talk and be happy to answer any questions. I'm also participating in the Run for IVU, and I'm almost at 100 miles for the month. So, it really helps to have the stationary bike, but to get those miles up. But it's been really fun to participate, and I've really enjoyed these opportunities. So thank you so much.
Thank you so much, Dr. Marah. Thank you for your presentation. This was really a good summary, and especially how you demonstrated the step-by-step evaluation, and as well as the management for erectile dysfunction. We normally don't have a lot of options for treatment like you do. Mm-hmm. We only rely on the PDE5 inhibitors mainly. But I have a question for you. For older men, do you normally assess their prostate as well when they come with a complaint of erectile dysfunction? Do you do a prostate assessment as well, or it's not necessary?
I usually have older men, when they come in, I give them 2 questionnaires. Typically, one is the erectile function questionnaire. I just use the SHIM, the Sexual Health Inventory for Men. Mm-hmm. And then I do the International Prostate Symptom Scores, the IPSS score. And mm-hmm. I usually do ask them about their urinary function as well. And of course, through that validated questionnaire, I have a little bit of data to go off of whether they need treatment for their prostate. If they aren't having any urinary complaints, I don't usually do a prostate evaluation like a PSA or a rectal exam. But if they have any symptoms, then obviously they're in a urologist's office, and I think we should treat as much as possible. So absolutely.
Yes, I don't know if Dr. Shamani wants to add something.
Yes. Thank you, Marah, for your for your topics. It's very, very interesting. But personally, I can say that I am very, very poor for this item, for sexual dysfunction. Why? Because here we have many cases, many patients which this problem. But as you say, I think the principal etiology can be the stress, because here we have a low country who have many problems. So personally, I think that we have a stress as a principal etiology of erectile dysfunction in our countries. And also, we haven't any expression like penile duplex Doppler. We haven't it. We haven't it medication. Only we have a PDE 5I. Only this one.
Hmm.
We can do the vacuum, the VED. We haven't it. The intra-erectile, we can do it. So thank you for more information. So I think we still poor to treat this kind of patients. And so what we do, personally, I use the PDE 5 and also the lifestyle modification. We have only kind of treatment to propose for patients. So thank you very much. But my question: who do the penile duplex Doppler ultrasound? It's the radiologist, or you can also do it?
I do it myself in my patients. I know many colleagues do it themselves, but some of my colleagues at other locations have a nurse practitioner or someone, some staff working with them who will do it, or they have radiologists do it, but I personally do it myself. I think it's like I mentioned, there are so many nuances to that test that I think it's important to sort of know what's going on with the patient right at the time of the exam and not just have the numbers. So you can see it for yourself and kind of counsel them appropriately.
Okay. Just I can ask you to Kati. If possible, can we have the slides for this session?
Yeah, do you want to send them to me?
Yeah, absolutely. Happy to.
Yes. For me, I also have another question. In your practice, do you mainly our questions will be on the PDE5 inhibitors, because that's what we have. That's basically the only treatment option that we have. So do you in your practice have a maximum dose that you give per age? Like maybe in young healthy adults, the maximum dose that you can suggest, and in older men, the doses that you can suggest. Do you have something like that?
I use the same dosing regimen for all men because what we've seen in the literature is that the risk of having a priapism, the erection lasting, more than 4 hours is extremely, extremely low. So really, I think the dosing is limited by side effects. And so for sildenafil, my maximum dosing is 100 milligrams. And we can get, so we have the access to generic tablets of 20 milligrams. And so they can scale up from 20 to 40, 60, 80, et cetera. And then for the tadalafil, the maximum would be 20 milligrams, and they can scale up on 5 milligram increments.
Mm-hmm. So you always start by the lowest dose, and then you will be increasing as time goes by, right?
I think in men who maybe have diabetes and who have severe ED, I usually start at sort of a moderate dose or just a high dose. I think it's, it may not be, while they may respond best to the highest dose, and I think they need the highest dose, I want to see how they tolerate the side effects at a more moderate dose before they scale up.
Mm-hmm. And for patients who have yes, Dr. Shawani.
Yeah, I think as she says, it's very, very good to start with the low dose. Why? Because now in our country, I have some cases who patients with automedication and who takes Viagra for high dose, and so we have some cases of a stroke attack. So I think it's very, very better to start with the low dose and go up slowly, I think.
But in our country, the lowest dose that we have for sildenafil is 50 milligrams, and the lowest dose that we have for tadalafil is 20 milligrams. We don't even have any other. So maybe. Mm-hmm.
Do you have patients cut them in half?
Yes, or in quarters even. Yes, that's what I normally do. I try to start them on 5 milligrams when they are using tadalafil, and I ask them to cut into 4 pieces.
Yeah, absolutely.
Mm-hmm.
Personally, I started with a half of tablets, so as 2.5 milligram.
My next question was on patients who comes to you with another etiology, let's say hormonal issues.
Mm-hmm.
If, for instance, their LH is high and their testosterone is normal or low, what do you do? Are you the one who treat them, or you send them to the endocrinologist?
Either or. So if in older men, we see that pattern that you just described where the LH is high and the testosterone is low. That's sort of just indicative of their testicular failure. And usually that's age related. And I do think that men can benefit from testosterone. I counsel them that they may not get back the erections they had when they were young just from being on testosterone. But I think it is beneficial from an erection standpoint and also a cardiovascular and bone health standpoint to have normal levels of testosterone. So I do manage testosterone. Or I'll send them to endocrinology. I think it's easy enough to manage myself. So, and then keep an eye on their ED, and then they're not seeing a whole bunch of different doctors. So I usually manage it myself.
By giving testosterone replacement therapy?
Yes, yeah.
Okay. Mm-hmm.
And then we talk about all the different options that we fortunately have for testosterone therapy. Gels, patches.
Yes.
Yeah, injections. So
We only have pills.
For testosterone?
Yes.
Okay, gotcha.
Mhm.
Yeah, I think, a lot of my visits about erectile dysfunction are talking, it's talking about these options and really educating men on what is going on. And so they definitely feel more informed at the very least. And I think that's really one of the best things that we can do. And also just making sure that they're, if I'm the only doctor they're seeing and I'm the only one telling them to quit smoking, that's really important, so our visits have a great impact.
Mhm.
So do men that you see, do they do research online? Do they have the ability to see what other options are out there?
Yes, they do. They, with Google,
Yeah.
they always come up with they most of them have read what can be done, but we always have to tell them the options that are on the table for us now. Yeah, which are using the PDE5 inhibitors.
Yeah. Yeah, I wonder,
We
something.
also, yeah, so we also use some supplements. I don't know if you've do you have some kind of supplements in form of pills. We have supplements made of L-carnitine, vitamin B. What's your impression on those? What do you think about those?
Yeah, I definitely know. I talked to patients about them somewhat. I know other colleagues of mine who frequently use things like L-carnitine or L-arginine to give, a little bit more blood flow. And I don't think that they're dangerous. So I think that's reasonable and may be helpful. And the mechanism of action makes sense. And what else? Yohimbine is a supplement that is used most commonly for ejaculatory dysfunction. So delayed ejaculation, it can help with sort of making the ejaculation short, duration shorter and more powerful. So that's another supplement that we talk about with patients.
Okay.
You do penile implant surgery?
No, we don't have those.
Yeah.
No, my practices, no.
Yeah, I think like I said, patient satisfaction is so high. But it can be really challenging for a man to want to have a surgery for this, Some men are very motivated. I'm sure you've met men who are very motivated and read about these things online and want to go to the end of the earth to preserve their sexuality. Do you see a lot of mental health issues after, if they're not, responding to treatment?
I think most of them give up. They would just decide to give up. And most of these patients who don't respond to treatment are older men, especially those with hypogonadism. They've tried testosterone replacement therapy. They've tried the tadalafil or sildenafil, and they still don't see. They're still not satisfied. So for me, what I've realized, most of them would just give up.
Yeah.
Yeah.
Yeah, I mean, especially older gentlemen, they really don't respond to those treatments, or men who've had prostate cancer, prostate surgery. They are not going to respond very well to the pills. And, I feel fortunate that we do have a lot of different options for them. But even with the options, some men, again, just, they don't want to use needles. They don't want, another surgery. And so they also are just saying, I'm fine just having my wife, as, you know, and not having that aspect of our relationship.
Yeah.
It's possible to have for example, some donation or something for other kind of treatment, erectile dysfunction, like penline prosthesis, because here we haven't it. Also the vacuum erectile device, we haven't it. I think is very, very good for us. If we can have mankind of treatment, because when, for example, for patients who operated of prostate cancer, you can have the erectile dysfunction, and so I think the solution can be, for example, the penline prosthesis. So it can play it for us to have it.
Yeah, I would have, you know, we have, as I mentioned, I work with those device companies closely. And, you know, I'd have to, I'm sure that they would be interested in expanding their business. But that would be, you know, more on that corporate level. I would love to, you know, I would be my pleasure to come do teaching and do some of these procedures with you guys. That would be very fun and a great opportunity.
Sure, that would be a very good opportunity. Maybe for the first few samples, they can provide free samples, and then when patients, you know, here they talk a lot. When patients hear that information, then it can really be a good opportunity to start
Right.
such kind of business. Yes.
Right. We, you know, in the United States, we do more of the inflatable implants. But in the UK and in Europe, they do many, many more of the malleable, the semi-rigid. They're easy to put in, low rates of complication, and they're much less expensive devices in general. So, and that's why, because just with, you know, the healthcare system in the UK and in Europe, these devices are paid for by, you know, state sponsored medical insurance and medical care, that they use the more cost effective route, and their, you know, satisfaction rate is still very high.
Yes, I've also read some articles from Morocco. They were also mainly using the semi-rigid, the malleable implants. Yeah, I think those ones are cheaper and easy to insert, as you were saying.
Yeah, we,
yeah.
in my training, we
can yeah.
Yeah, we actually, you can put them in under local anesthesia. So very low, you know, resource requirements for those procedures.
Yeah, and yet very satisfying.
Yes.
Yeah.
Sorry. Also, I have some patients who use traditional medicine. As you are in Africa, the traditional medicines is usually used. So they took me the feedback. They come with the feedback is that the traditional medicine is good for her to treat, for the treatment of the erectile dysfunction. Personally, I have an ambition to make the study of the study about this kind of traditional medicine and erectile dysfunction. So I don't know. I don't know if Ms. Galina or Ms. Sarah can be interested for this one, and can make the comparison. Yes, just to see if the traditional medicine can be the solution for erectile dysfunction.
Yeah, I'd be very interested to see a study.
Okay, thank you.
Thank you. So my email is here if you have any other questions, and I'll send Katie the slides to share. It's a real pleasure connecting across the world. It's so, I feel so fortunate that we're in the day of age where we can just talk across the entire world face to face. And it's really my pleasure to meet with both of you.
Thank you very much for making this presentation for us, and for all the discussions. It was really really fruitful, and it is also a way for us to see what's happening elsewhere, and this prompts us to improve our management, how we treat these kind of conditions, because they are there, and there are really many these kind of conditions. So thank you so much.
Yes, thank you very much.
Yeah, thank you so much.
Thank you very, very much. I hope to have another opportunity with another topics.
Anytime.
Yeah, thank you so much for
Thank
presenting, and thank you both for attending.
Yeah, thank you, Kati.
Of course. I hope you guys have a nice night, and I hope you have a great rest of your day, Dr. Heeman.
Okay, take care.
Bye.
Bye, guys.
Bye.